I'm here with Nicolo Piazza from Canada and Chaim Lotan from Israel. Nico, why don't we start with you? Why don't you give us some idea? Yesterday was the third Innovators Day program. Give us some idea of what we are trying to do with Innovators Day.
Yeah, so Innovators Day, it's a special day, in fact, that traditionally occurs one day before the actual kickoff of PCR. And it's intended to bring together physicians, industry, venture capitalists, engineers, all together in one room to discuss really the challenges that we face in innovation.
So Chaim, I know that the idea originally started with a program that you run in Israel called ICI. Tell us what ICI is and how what you were doing at ICI became Innovators Day.
Well, actually, the idea that Nico mentioned is that the unmet needs are usually brought by the physician. But you need a unique environment, including the bioengineer, entrepreneurs, the VC, to understand what are the unmet needs, what are the challenges, and if you bring them together, realize that it's very fruitful. We started, as you mentioned, the ICI meeting, which became a huge meeting, and part of this was brought here to bring in the people, and we can see that it's growing very rapidly, and more physicians are interested to understand, see, and contribute to what's going on.
So let's focus on some of the technology areas. Nico, you gave a great presentation yesterday on one of the hottest areas in cardiovascular devices today, and that's mitral valves. Give us a little bit, if it's possible, to summarize the point of your presentation and where do we stand today in mitral valve?
Sure. So it was interesting to see that we have over 50 companies or devices in the mitral valve space, whether they be repair or replacement. There's at least, from what we know, 16 repair devices that have already been implanted in humans. 5 of these have CE mark approval. And there's over, I would say, 6 companies who have already performed mitral valve replacement. And this all happened in the last 3 to 4 years. So there's a real boom recently in transcatheter mitral valve interventions.
Do you see it going toward repair replacement predominantly? There's a third category, tricuspid. Do you have a sense of how the landscape will shake out in terms of where this technology will be used?
Yeah, we were discussing yesterday that there's going to be probably a place for both repair and replacement in the future, and it's really going to be about patient selection. And some of the things that we were discussing is that there's going to be discussions surrounding safety, effectiveness, reproducibility, user-friendliness, and durability.
So Chaim, a lot of these technologies, several of these technologies have come out of Israel, like ValveTech. Give us a sense of where you think mitral valve is going in the future. Do you agree that there's place for both replacement and repair? One prominent interventionalist leaned over to me and said, this is only about repair because replacement does great surgically. I'm not certain why you would do this for replacement. Give us a sense of where you think this field is going.
I agree with Nico that we'll have place for both of them, and patient selection will be important. We do see that there are already patient mitral repair, but it doesn't hold. So if it's a very elderly patient and you repair it for 2-3 years, it's okay. But if we are moving into younger patients, we want to be sure that we have a replacement or a repair that will take and be sustainable. So I think that at the end, it will be both. I'm sure that it'll take more time than we expected. Mitral valve is much more complex, and now we see it than TAVR. It wouldn't catch up. We'll have to have a very long learning period to understand exactly which one is better, which cases, patient selection. But ultimately, I do believe that at least part of what we're doing now in surgery, or we are not doing at all, will be done in the cath lab.
So before we move on to the next subject, I just want to pick up a point, Nico, that you made about there being 50 companies in the space. There's 50 companies in the space, more coming down the road. And I guess that raises 2 questions. Are there unmet needs still in mitral valve, clinical problems that have to be solved that would open the door for new companies? And what happens to the 40 or 45 of those companies that haven't been acquired, that haven't found an exit yet? If you are 6 years old working on your mitral valve technology and more people are coming, do these companies have a future?
One of the things that these companies will need is imaging. And so there was a comment made yesterday by one of the attendees that perhaps these device companies should work closer with imaging companies. And I think that was an excellent comment. Imaging is really the eyes of the heart team, and that was repeated a few times yesterday. And really, as Chaim was saying, it's a complex valve. And the only way we're going to understand where we place our devices is if we can see both the anatomy and our device. And you got fluoroscopy that gives you a great understanding of where your device is, but it's very difficult to understand the fluoroscopic anatomy if you don't understand the CT scan. And then you got the echo, who gives you, beautiful images about the anatomy, but very limited information about your device sometimes because they're not all echogenic. So you really have to mix and match all the imaging modalities to get this successful.
Do you see any young companies right now focusing on imaging as an important adjunct technology to the valve itself?
Chaim, I don't know about you, but when these device companies come about and speak to us about their technology, it all revolves around patient selection with the imaging.
I definitely agree that imaging is going to play a major role in patient selection, in understanding. But I think durability is also going to be very important. We do have very good durability of TAVR today, but I think with mitral, durability of either repair or definitely replacement, because of the changing nature of the valve, is going to play a major role. So I think that we still have a long way to go until one of them will be really approved.
And this actually brings up another important point, that if durability is going to be a problem, that we should have the opportunity to re-intervene in the future in these patients. So, for example, if you're going to put a mitral clip and that fails, well, it's very unlikely you'll be able to do a transcatheter mitral valve replacement in the future. On the other hand, if you put in a cardioband, and you get a decent reduction in MR and the patient feels well, and for some reason that fails down the line, well, you can always put in a replacement device. So the idea of combining repair devices or repair replacement devices I think is going to be very important down the line.
I simply will make one comment before we move on to the next subject, and that is, from my perspective, it's interesting to note that the TAVR devices, the first generation technologies, are still the market leaders by a wide margin. And some of the second generation and even third generation technologies have yet to find an exit. One would have thought that by now, and not to diminish the prospects of JenaValve or Symetis or direct flow, we saw yesterday direct flow switching to mitral valve. But it is interesting to me that in aortic, we haven't seen the great run-up of companies that we've seen in mitral valve.
If you have 50 companies, it means that no one has the best solution.
Right.
So the more companies you have, you understand that you don't have one good solution, and probably it'll be a mixture of several solutions to several different subpopulations, and it's going to take a while to understand, swallow, and absorb all those kinds of sub-patients.
But for market, for that market share, I think speed is going to be very important. We heard Martin Thomas.
In what sense?
Well, we heard Martin Thomas say yesterday, one of the reasons why they acquired Cardiac was to accelerate their position in the field. And given their resources, they can potentially take a therapy that has already been escalated in men to another level. We saw Edwards and Medtronic, who are the market leaders in TAVR. They were the first ones there. Right. It's not to say that Symetis and Direct Flow and all these other valves don't have a great valve. They do have a good valve. Lotus, for example,
but
as well.
Being there first is
exactly
important. And people spoke of the first mover advantage yesterday. Well, we probably should move quickly to the other ones. The structural heart session yesterday focused on heart failure, and I wonder if you could just give some thoughts about where you see the technology and the clinical practice going in heart failure. We saw both chronic and acute decompensation, and then some of those technologies were neuromodulation technologies, somewhat differently. Give us a sense of what's coming in heart failure.
Well, heart failure is divided into two or three. First of all is detection, deterioration of patient. We know that heart failure is one of the major reasons for readmission. And the question is, how do you detect early? And this brings me to the whole issue of the digital revolution, e-health, and a lot of companies that are trying to predict which patient is going to deteriorate and maybe prevent deterioration, which is a major issue, and this takes out of the hospital patients in their home and trying to see, and there are a bunch of excellent companies that in the future will be integrated to the health system to predict which patient will be. So I think early diagnosis and the e-health is going to be a major part. Second part is what we do with the patient once they are in the hospital. Unfortunately, we know that drugs have failed. We do have several ideas on either neuromodulation to divide the balance or redistribute the balance between the sympathetic and parasympathetic, and we have very nice early results. And we're still waiting to see whether we have good mechanical solution. I think that the mechanical part is still waiting to be done. We see some advances with the mechanical LVADs and LVADs-like system, but this is a real problem. So I think that here maybe we'll have to wait for real solution for stem cells or other solutions that are 10 years apart from us.
So I want to pick up on your comments on e-health. Before I do that, Nico, let me turn to you and just ask about your thoughts on heart failure and where you see that treatment and therapy going.
Yeah, you know, the whole concept of interventional heart failure is a growing field. There aren't many, I would say, centers in the world who have a department dedicated to interventional heart failure. And this is because we don't have any good devices yet. For instance, yesterday we saw something interesting, you know, someone putting in a device within the renal vein in order to decompress the renal vein and bring that blood into the right atrium in order to improve the filtration of blood through the kidneys and improve diuresis and get patients out of heart failure. So we're starting to see these novel interventional devices that might find their way into the cath lab. But the market opportunity is there. We still don't have good devices.
So I'm glad you raised that way, because let me ask you one other question about that, which is we've seen over the last decade a new specialty emerge, heart failure specialists.
Yeah.
Will this be, as revascularization was 20 years ago, a turf battle between interventionalists and cardiac surgeons? Will we see a turf battle between heart failure specialists and interventionalists, or are some of those heart failure specialists interventionalists who have kind of redefined their practice?
I think it will be both of them, actually, because it depends which devices will come in. For example, there is a device started in Israel, the V-Wave, that is shunting blood from the atrium when you have higher pressure, so that definitely can be done by interventional cardiologists. Some other devices like Circulite or whatever may need surgeons. So it really depends, and you will have, like you mentioned, to build a team. And it's not a one person, it will be a team like we have today, the structural team that takes the interventional cardiologists, the imaging people, etc. We'll have to build a team around heart failure, and it depends which devices you use and what the imaging and everything. So it will be a team which will follow the patient from outside to inside and backwards.
And my sense is that those teams were difficult to build early on, but after the bruising battles around revascularization and valves, it seems to me that physicians are more amenable to team building today than they might have been 20 years ago.
The team approach is catching more and more, and we do understand that today with all the complex imaging, you cannot do everything yourself. It's not the days where you put a balloon in the stents and you're done. It's much more complex. You need more hands, you need visualization, you need understanding, and I think the team approach will win at the end.
Chaim, let me ask you a question. There's been, you've been through the innovation cycle, for a number of years now. It seems as if the interventional community focuses on one innovation at a time. We went from balloon angioplasty to bare metal stents to drug-eluting stents to renal, valve, maybe TAVI we should say, and then to renal denervation. Now we're into mitral valves. We're starting to hear about tricuspid valves.
Right.
Now there is this, concept of interventional heart failure. Do you think that it takes the community requires focus in order to develop to face the challenges and find the solutions to these challenges.
I think that's a great question. Before you answer, I would just add to it that industry follows that pattern. So
Yes.
you see the industry itself funding a whole bunch of aortic valve, a whole bunch of stent companies and a whole bunch of valve companies and a whole bunch of renal denervation companies and interventional heart failure. I think will be next.
So Chaim, I'm saying this because it is the reason why we don't see the developments in heart failure, because we're all focused right now on valves.
Definitely part of it, but we have to walk before we run, and we have to understand and go slowly. Interventional cardiologists in a way are conservative, but the market is also led by the companies, by the big money.
And by the venture capitalists.
And the VCs, exactly. And they have to realize that there is a potential. So it's a slowly progressing thing. I just had a talk this morning with a colleague of mine that said that 25 years ago, when we did a balloon, it was, the end of the world, that you can do it in 2 hours. And today, you don't even let your young fellow do it. So if you look about the revolution that was done, it's really amazing. We are in it, and we cannot really understand what it takes. Now, definitely, you have to focus, and focus means not only your attention is money, and where they make money. And it took some time for the companies. If you would have come to the companies 5-10 years ago, talk to them about the mitral, they will throw you away. So they have to be convinced that there is a market, that there is capability, and definitely we're trying to solve one problem at a time.
Well,
and definitely, heart failure is going to be the next
But speaking
huge
of that
problem.
point, early on, New England Journal of Medicine was writing editorials against stents. When the percutaneous valves first came out, people were saying you can't put valves in percutaneously. And the first thing a venture capitalist is going to do is going to call up some interventionals and say, hey, someone's talking to me about this interventional heart failure model. Can this work? And if the interventionalist is in the wrong mood, he'll say, oh, that's a crazy idea. I'd never do it. And the venture guy goes, you know what? We'll take a pass on this technology. So it's a kind of vicious cycle.
Evolution. I remember a VC told me that early on he talked to a surgeon about TAVR, and he told him that the stupidest idea that I can hear, don't even put a penny on that.
Right.
So, it's a normal evolution which we have to undertake, and here we are.
So that leads perfectly into the next section we did yesterday, which was e-health. And I would just tee up your thoughts on e-health by saying that unlike valves, that unlike heart failure, I got the sense from people on the panel that there was both interest but also skepticism and kind of what are we really doing here and what's this all about?
Well, because it's a totally different world. We are in a revolution which is taking us out of the cath lab to the patient's home, to the hospital in a different situation. It's not the same model that we use, that you have a device that you use in the cath lab. It's different idea of different device, different models. Who's your customers? The patients, the physician, the HMOs, the VCs. So it's a whole different way. On the other hand, it's a revolution and it's going to occur. If you look about your cell phone 10 years ago and now, it's a total revolution. We don't feel it. So if you want to imagine what will happen in 10 years, medicine will change. So patient solutions, patient education, everything will be done in a different way, and we have to adjust ourselves to those kind of changes.
So Nico, people talk about a generational divide in e-health. You're the young one here. Are you more intrigued and more accepting of and more enthusiastic about digital health than graybeards might be?
It was what struck me most yesterday, and something I never thought about was cybersecurity.
Right. Peter Fitzgerald made that point.
And it was impressive to hear that there's over 100 million patient files that are hacked per year. And with the ability to extract social security numbers, to file taxes with this information, and so I think it's going to be extremely important in the future. We're going to be able to develop artificial intelligence using large data sets. And we see it in our clinical practice. Our brains every day take in information and we somehow manipulate that information. And it makes a difference if you've done one TAVR versus 6,000 TAVRs. And we develop that database in our minds. And this is what people are trying to do now with artificial intelligence, and it will penetrate the medical market.
No question. When I was a medical student, my old professor used to say, from my experience, and that was that. And my experience was based on 10 patients, 15 patients. Now, when you bring in the experience of 500,000 patients, and you do it within seconds, definitely it's going to change everything. And we had yesterday excellent examples
the ECG.
Of things, the ECG and other things, how to extubate a patient, based on but if you have a list of parameters and you put it in a computer and you can know that you can extubate safely or not, that's going to change. So
the important thing is that, despite all of this artificial intelligence and the use of software and hardwares to improve patient care, the other important point that was made is that the physician needs to remain responsible.
Right.
And it's very difficult to remove the physician from the equation.
Yeah.
So, I think these are going to facilitate physician decisions. They will not replace physicians.
Yeah, I'll just say parenthetically, we just did an article on the Johnson & Johnson Google joint venture in surgical robotics, and when those guys talk about the benefits that Google brings, it's about machine learning, advanced analytics, better decision making in the operating room, because you can aggregate so much data in one spot.
I think that, for years the IT and the MT were parallel, innovation technology and medical technology, and now they're merging together. Right. You see a lot of companies that are coming together. So you have Google and Samsung and Medtronic and everyone, Abbott in the same pot, which means that you need a lot of things like a teamwork that we discussed in order to solve those. But it's going to be there. The concept of smart houses and everything will have sensor that will give us a lot of data. The question is how to deal with so much data, and big data is becoming a real issue. But definitely it will change the way we're taking decisions, and maybe in the future you will know which patient should get which mitral repair based on those data.
Well, the whole discussion is leading us to what I think should be our final point of discussion, or maybe just spend a minute or so on one of the sessions that we did yesterday, which was on business models and whether we have the appropriate business models for bringing innovation forward. 20 years ago, the model was very clear. Physician came up with a good idea, found some venture capital money, developed a product, maybe didn't even need to get to commercialization, and sold to a big company. Today, it's a lot more difficult. There's a lot less money. It's taking a lot longer. What do you see in the business model?
The question is, who's your customer? And with those changing things, it's not one customer, and who is going to pay is the question. Either it's a wellness app that the patient will pay, or the normal. Is it something in the hospital? And some of the applications, actually, the hospitals are ready to pay, let's assume, for preventing patients for recurring admissions. Is it the health provider in general? So it's a big question, who is going to pay, what are the business models that we applied. So we are kind of a changing paradigm, which is taking things from the cath lab outside, and outside it's an open world. Also, regulation is a big issue today. What kind of regulation? So I think that we are definitely moving there, but there are a lot of issues that will need to be solved with regulations, with business model, with responsibility, and what's the place of the physician at the end of the day.
So Nico, I'm going to let you have the final word here, but I will just say parenthetically, one of the other sessions we did yesterday was on health economics and how cost to the system, the cost pressures on the system are bringing it. So let me ask you, we've got tremendous unmet clinical needs still. We've got all this exciting new technology out there, and yet it seems harder and harder to bring technology to the fore. Are you optimistic? Are you pessimistic? Give me your sense of what you think your toolbox will look like 20 years from now.
It's clear innovation is still thriving. The fact that we're having these special days means that something is happening in the innovation field. And there was so many innovative devices yesterday with interesting discussions. One thing that was brought up by one of the audience members was the whole concept of, maybe overcoming these cost pressures by going into the emerging markets. I thought that was really, I think that was really interesting.
Yeah.
And maybe next year, as a topic of interest, would be to talk about innovation within emerging markets.
That's right.
And you know, I've been to China now several times doing some transcatheter aortic valve replacements with a Chinese valve. And I have to say, I'm extremely impressed with the safety and effectiveness of the device that parallels that of, you know, the Western devices that we have right now. So I think we could, you know, go to the emerging markets, not only, you know, for industry, but also I'm sure there's venture capitalists in these emerging markets.
I was going to add that it's interesting because a significant portion of American and European companies are now looking to China, Singapore,
Correct,
as places to raise capital.
And maybe bring the issue of reverse innovation, where some
Right.
things will start there and eventually will come, like leadless pacemaker. That, you know, the idea was to have a cheap pacemaker without leads for the emerging market, and now it's becoming a big boom back in the United States and Europe.
Well, I will say this, when I go to ICI in December and you go to that breakfast room in the morning, there are more Chinese people there than there are
Exactly.
Americans. Great. Well, I think it's a great wrap-up. I think it's a great point about innovation, Innovators Day, because that's what we're trying to accomplish here, is to raise these issues and to kind of foster an environment. So let me thank you too for sharing your insights, and we'll turn the program back over to our hosts here.
Thank you,
Thank
and
you.
see you in December.
See you in December. I absolutely will be there.
Okay, thank you.
Thank you.